Here at the European Cancer Meeting, I've presented the results of POPLAR. That is a randomized phase 2 study, but it's almost 300 patients, comparing immunotherapy, which really is in the focus of modern cancer care, immunotherapy with anti-PD-L1 antibody atezolizumab, with standard docetaxel second-line chemotherapy in patients with non-small cell lung cancer. So it's really a comparison of what we have as historical standard docetaxel, which is not exactly very good, with a modern type of anti-PD-L1 immunotherapy. And what has been presented here was the primary analysis of efficacy, safety and biomarkers. In the POPLAR study, what we noted was a significant overall survival benefit of atezolizumab immunotherapy versus docetaxel, with a hazard ratio of 0.74 and a p-value of 0.04. This is important, as well as the fact that the toxicity for the patients of the immunotherapy is clearly less than with single-agent docetaxel chemotherapy. Of course, we also want to know who are the patients that have most of the overall survival benefit from this new treatment. So this is the question about biomarkers. And what we noted is that the technique we used in POPLAR is a bit different from other techniques. It looks with a very sensitive antibody both at PD-L1 staining in the tumor cell and in the surrounding immune environment of the tumor. And what we feel from that analysis is that both may be important, because actually what we have seen is, first of all, the stronger the staining is, the better the overall survival benefit was. That's one thing. And the second thing we noted is that PD-L1 staining on tumors clearly contributed to efficacy, and this is what we know also from other data sets, but also PD-L1 staining on immune cells independently contributed for some patients to the efficacy and overall survival improvement of atezolizumab. So probably looking at the tumor only may miss some patients that have real benefit. So this is really the originality of this data set, that it's a mixture of immune expression both on the tumor cell and on the immune environment. The presentation at the European Cancer Conference was the primary analysis of POPLAR. This means an interim analysis had already been presented previously at the ASCO meeting. The main difference is that with longer follow-up, you see that the overall survival curves continue and even have to have a separation, and the separation even increases. This means that is probably related to the delayed effects of immunotherapy in patients, and this means that in comparison with the presentation at the ASCO meeting, where the overall survival was not yet significant, it is significant now, and you never know the future, but most probably with ongoing follow-up it is likely that the hazard ratio will even further improve, because we now have follow-up data of a minimum of 13 months. I think with increasing follow-up, the curves may even separate further, the hazard ratio may even become stronger, which is nice because at the end of the day it's a phase 2 randomized study, but it's almost 300 patients. It becomes a very strong, significant signal, and what we are waiting for now obviously is a true phase 3 randomized study with exactly the same patients, the same design. This study is running. The study is at the present time fully recruited. It's the OAK study, and we really look forward to the next results of that OAK study that hopefully will confirm the significant signal that is already there in POPLAR. In terms of safety, side effects for the patients, we know that docetaxel is not a very well tolerated treatment. In this study, in POPLAR, what we noted, and this is in line with previous data that we know for docetaxel, is that the grade 3, 4 and 5 toxicities with docetaxel occurred in about 40% of the patients. If you look to immunotherapy with atezolizumab, you see that this figure is only 13%, so it's clearly less. And actually it's only a few patients that have a grade 3 toxicity that is really treatment related, and then often it's a particular type of toxicity. It's an autoimmune toxicity inherent to the mechanism of action of the drug. So there was one patient, and that's important, with a grade 3 pneumonitis, and then you really need to act you need to know this as a doctor how to treat this. This is what happened actually with this patient in this trial. The patient received corticosteroids, the event was treated, and actually he could continue with atezolizumab later. So it's a different toxicity, clearly. It's far less than with chemotherapy. It's different. It can be dangerous, you need how to handle it, but if you do this, overall the treatment is far better tolerated than docetaxel chemotherapy. One question we have with immunotherapy at the present time is obviously, we know that in relapse treatment at the present time, different immunotherapies clearly have major advantages for patients. The next thing is now thinking about combination therapy. One of the combination therapies may be combining immunotherapies with chemotherapy, and that is currently being explored in first-line trials. Another potential combination is combination of two immunotherapies, one working on PD-1, PD-L1 with one working on CTLA-4. These trials are ongoing as well. And then finally, we know that one of the big successes in non-small cell lung cancer has been the use of targeted agents in patients with oncogene drivers for ALK mutation, for ALK translocation, for EGFR mutation. So combining immunotherapy with these targeted agents in these specific subgroup is also of interest, and these trials are really at the very beginning in early phase 2. Can I do this again? It's not good.
The whole answer again.
Yeah.
Is that the problem? Okay.
Ask the question again.
Do you think that there is a future in the clinic for trials that combine both immunomodulatory therapies with compounds targeting tumor intrinsic pathways?
So after the results of POPLAR and other trials, we know that immunotherapy with anti-PD-1, PD-L1 antibodies is really a new option for treatment at the present time in relapse therapy. So the next will be to look if combination might do better. And there are different possible combinations. The one is, does immunotherapy add to chemotherapy? And that is predominantly explored in the first-line therapy of non-small cell lung cancer in ongoing randomized phase 3 studies. The other possible combination is different immunotherapies, different checkpoint inhibitors, tackling different checkpoints, meaning PD-1, PD-L1 combined with CTLA-4, so giving two antibodies and see what happens. What may happen is increased efficacy, what also may happen is increased toxicity, and this is ongoing, we don't know yet. And finally, the last one that may be of interest is one of the big progress over the last 10 years in non-small cell lung cancer is oncogene drivers and targeted therapies, EGFR mutation, ALK translocation. These give fantastic results, but all the patients develop resistance. And so maybe one of the ideas is if you combine targeted therapy with immunotherapy, you may at least delay or overcome this resistance, consolidate the response achieved by targeted agents. I think it's a very good idea, but that is really an early exploration. Most of these explorations are still in phase 1, and we really have to see what happens.